Hi, everyone, and welcome to our August edition of Hot Topics, Acute Pain and Regional Anesthesia Edition. As always, I'm your host, Jaime Baratta, coming out of Thomas Jefferson University in Philadelphia, PA. And today we have a great panel of speakers talking about education and how to improve the teaching of regional anesthesia. Now I'll introduce our speakers. Our first speaker is Dr. Rachel Outterson, who practices regional anesthesia at Stanford, where she focuses on resident education and improving environmental sustainability of anesthesia practice. And she'll be speaking on how to create an effective workshop. Next up will be Dr. Garrett Burnett, who is an assistant professor at Mount Sinai, where he serves as the director of operations and program director for the MOCA course at the Mount Sinai Helps Simulation Center. And he serves as the podcast website liaison for the ASRA Education SIG and on the technology committee for the Society for Simulation in Healthcare. He has led workshops at a number of meetings and has extensive interest in simulation and cadaver-based education. He'll be speaking about those interests and how to utilize them in education. And last will be Dr. Parvinder Sodhi, who is currently a staff anesthesiologist at Nova Scotia Health Halifax and an assistant professor at Dalhousie University. She is active in education as the lead of the resident regional anesthesia and acute pain rotation, and she'll be speaking on teaching and ultimately evaluating success. Now I'd like to hand it over to my special guest co-host tonight, Dr. Kwesi. Kwofie is going to introduce himself and how this session came about.
Good, thanks so much, Dr. Baratta. So I'm Kwesi Kwofie. I'm an associate professor and chief of regional anesthesia at Dalhousie University. And I also wear a couple other hats. I'm the CME lead for the education special interest group at ASRA, and I'm also the associate editor for regional anesthesia on the ASRA News. And in sort of those two hats, particularly at the education special interest group, we were discussing, what are the real key topics that we need to be sharing more. And one of the things that came up was, how can we help to mint the best teachers, and really how can we teach the teachers how to be the best that they can be and hone their skills, both for teaching at ASRA and teaching in their own institutions and supporting the increased use of regional anesthesia. So out of that discussion, we amassed a great cohort, and you have some great experts to come and share their knowledge about all aspects of teaching. So we're really excited for this session today. So thanks so much.
Yes, and thank you. I think it's so important, no matter where we are in our career, that we can always improve how we teach and we can always learn. So just a reminder, post your questions in the chat or the Q&A box, and we monitor them at the end of the session where we'll have a nice discussion about this topic. And now I'd like to hand it over to our first speaker, Dr. Outterson.
All right. So good evening, everyone. Thank you for joining. I'm Rachel Outterson, and I am one of the regional anesthesia faculty at Stanford, and I direct our regional anesthesia ultrasound scanning workshop for the residents. So I'm going to share the story of how our workshop series came about, what we choose to teach, how we teach it, and what I've learned from doing that, and what I would recommend for those looking to implement a similar workshop series in their own residency program. So we'll start with a problem that many of you might be familiar with, and that is that there's so much to learn in anesthesia residency that our resident schedules are chock full of subspecialty rotations, and many residents might only get 1 month of exposure to performing regional blocks. So that's 1 month in which to acquire this skill set that they want and are likely to need in their practice. So in my illustration here, you see sort of the progress of the average resident across the three blue arrows that are the 3 CA years. So your CA1 is making their way across their first year, and maybe they hear about what a block is, maybe they get to see one, possibly do one, but they might still be largely uninitiated when they suddenly get this burst of exposure, probably in their CA2 year, that is their regional rotation. Suddenly they get to do lots of blocks and their hands get good and their scanning gets really good and they're on fire. And then after that, they go on to other rotations and the memory of that month starts to fade and they start to lose touch with those skills. And at some programs, as it is at ours, they might be able to come back again for an elective rotation, or they might not be able to fit that into their schedule. And so while every resident is getting the required number of blocks to graduate, or well above the required number of blocks to graduate, not every resident may feel comfortable enough to perform basic blocks in their practice. And to me, when I first started here in 2013, my impression was that the condensed nature of the regional experience was a main contributor to that lack of comfort. So in 2015, I developed our ultrasound workshop series to address this issue. I've illustrated the workshops here, each as their own little colored oval, showing where they fit in the timeline of the resident experience. And so the intention of this workshop series was threefold, one main goal for each of the CA years. First, for the CA1s, I wanted to introduce the concepts of scanning for regional anesthesia to residents who have not yet rotated on the service, so that when they show up to perform their first block, it's not their first time scanning for that anatomy. Second, for the CA2s, I wanted to deepen the knowledge of those residents around the time that they're getting all that experience on the regional service. And third, for the CA3s, my hope was to reinforce this knowledge in residents who have already completed the rotation. And the three goals together add up to this overarching goal of making the learning of regional anesthesia a longitudinal experience that would give our graduating residents the skills to practice the basic blocks they're going to need, and also the skills to continue learning regional anesthesia throughout their career. So the specifics of my curriculum are listed here. And when I first designed this, I chose the blocks based on what I believed residents were most likely to encounter in their training and then need in practice. That was my first guiding principle. What are they going to see that's going to be relevant to them? So that's illustrated in, for example, our CA1s start their first session when they're just learning how to tilt and rotate and apply pressure to the probe, focusing on femoral blocks, which they may see on their acute pain service as part of our hip fracture protocol that they may do in CA1 year, and then adductor canal blocks, which they're likely to see on their orthopedic anesthesia rotation when they're in the arthroplasty room. And then that idea of just making the curriculum relevant goes all the way through CA2s, going in deep on the blocks that they're most likely to see on service, and then CA3s finishing the year, their final workshop of residency, being the review of common blocks for private practice. This is a popular one because at this point, a lot of them know the practice that they're going to and know that they're going to have to do blocks there, so they're very motivated to review those blocks. Now, since the first implementation of the curriculum, other recommendations for regional anesthesia education have been published. So I've continually reassessed to make sure we're keeping up with what recommendations exist. And one of those sets of recommendations is the Plan A blocks. So this is this short list of 7 blocks that a regional specialist should aim to be able to perform in their practice. And those include interscalene, axillary, femoral, adductor canal, popliteal, thoracic ESP, and rectus sheath. So I've made sure that we've got all of those represented, most of them more than once, in our curriculum. And then another influence I've kept in mind with our curriculum is the new applied portion of the ABA exam, also called the OSCE, in which examinees may be asked to scan and identify landmarks for interscalene, supraclavicular, infraclavicular, axillary, TAP, femoral and adductor canal, or popliteal sciatic blocks. So residents are particularly interested also in reviewing these as they get close to graduation. So let's talk about how these workshops actually happen. Basically the same as the workshops at ASRA. So as I mentioned before, though, for the residents, they're divided up by class. So we'll have a 90-minute session, which is the protected teaching time that we usually have set aside for weekly lectures anyway, with just the CA1s, 2s, or 3s. We set up in a big classroom in one of the medical school buildings adjacent to the hospital, so everybody can make it straight from the OR, run over there. At the front, we have a large screen for presenting slides and then lead instructor up there. I'll have 3 exam tables with standardized patients, ultrasound machines, and then assisting instructors at each station, either a faculty member or one of our regional anesthesia fellows. And our usual turnout is about 12 to 15 residents. So they'll split up into groups of 4 to 5 learners per station. And then we alternate between brief slide presentations, ideally 5-minute introduction to the anatomy, and then longer scanning sessions where the residents get to really work in small groups with their individual small group instructors. And then the lead instructor can circulate answering questions, assisting where needed, and keeping things moving on time, which is pretty important. So just to give an example of what our slides are like, I might show the anatomy, probe placement, sonoanatomy of, in this case, the axillary block. And then I would briefly describe each of those and then leave up this slide just as a reminder of what they're looking for and set them free to go do their scanning. So we titled this presentation, How to Create an Effective Workshop. I have to make sure that I know it is actually effective. The things I have to go based on are our resident feedback. So luckily we've had some great feedback sessions and evaluations where the residents consistently tell us that they're practical and helpful. The junior residents say that they help them prepare for their regional rotation, and the senior residents are grateful that they help them refresh their knowledge. We also have the mock OSCE, which Stanford does every spring to help the CA3s prepare for the applied ABA exam. I got the opportunity to staff the ultrasound station this year and was able to witness firsthand how those residents who had attended my most recent workshop really aced it, finding all the sonoanatomical structures quickly and having enough time to spare, which is so important in the OSCE, very time limited. So after a few years of doing these, I have noticed some things that work and don't work. So for those looking to put on similar workshops in their programs, I would share a few tips. First and foremost, make the content relevant to the learner. Introduce the CA1s to the blocks they will likely encounter, go in depth with CA2s on the blocks they're going to see on surface, and then help the CA3s to focus on the blocks that they're motivated to know for exams and for practice. This seems to really keep the residents engaged and make the content stick. Second, I try to prime the residents for learning, which I mean in two different ways. First, I share the plan for the workshop a week or so ahead of time so they can get a chance to look at the slides and review that anatomy a little bit. As we all know, the ultrasound can only show you what you already know is there. So it's best to know some of that anatomy going into a session so you get more out of it. But I also think about the concept of priming the residents as in communicating to them that I think this is an important skill for them to learn and that this is an important session for them, because residents are very busy and they get a lot of emails and attend a lot of lectures. So I try to just drive home the importance of this by emailing the class myself personally and saying, I'm teaching you this workshop because I think it's important for your skill development. This is what we're covering. It's okay if you can't make it, but please let me know if you can. And with that kind of invitation, I find that I consistently get a great turnout of residents who come ready to learn. Using model patients is not an absolute necessity, but does make things easier. I've also had the experience of sessions where we weren't able to get those standardized patients and the residents scanned on each other. And in this case, it's just more difficult for that person who's volunteering to be able to actually participate in learning. Multiple instructors, that makes a big difference in a workshop. They don't all have to be senior regional faculty. Fellows are great in this role. Senior residents who are really into regional are great in this role. But I find that the number of instructors is the rate limiting step in the efficacy of a workshop. Trying to teach 12 to 15 residents by yourself just doesn't give them each the time and access to you that they need. Limiting lecture time. Just get the basics out there so you can really spend your time doing the hands-on stuff, which is the most valuable part of being there. And then finally, limiting the topics. I find with the CA1s, if you have a time constraint as I do of 90 minutes per session, with the CA1s, you can get through 2, maybe later in the year 3 blocks. With the CA2s, 3 to 4. And with the CA3s, when you're doing mostly review, 4 to possibly 5 blocks. So thank you very much for your attention, and please feel free to reach out to me with questions. I've got my Twitter handle there in the bottom.
All right. So my name is Garrett Burnett. I guess my video is blocked by the host, but I'm one of the regional faculty at Mount Sinai in New York City. I'm going to be talking about cadavers and simulation and using cadavers and simulation to teach regional anesthesia. Shout out to Patrick Mafucci, who is one of our senior residents who helped quite a bit with this project. So first, I wanted to talk a little bit about what the joint ASRA-ESRA recommendations are for ultrasound training in ultrasound-guided regional anesthesia. This joint recommendation from 2009 said that trainees should practice procedural techniques on available organic and inorganic simulators. Now, beyond this recommendation, they didn't say specifically what kind of simulators are best or anything like that, but a wide variety of simulation modalities exist that kind of exist at a range of fidelities that could be applied to regional anesthesia. This includes things like task trainers or like the blue block gel phantoms, live model scanning, cadaver-based courses, virtual or augmented reality, or even high fidelity simulation. Now, in terms of the evidence for simulation in ultrasound-guided regional anesthesia, this systematic review in 2017 showed that there was a significant benefit in knowledge and skill acquisition, but limited data on skill transfer to the clinical setting or patient outcomes. Now, most simulation studies this is a very common finding where there is limited data on clinical skill transfer or transfer to patient outcomes. So that's not really all that surprising here. In 2019, I did a survey study just looking at how simulation is used in regional anesthesia for residency and for fellowship, and found that about 80% of residencies and about 2/3 of fellowships use simulation as part of their training for regional anesthesia. By far, the most common were things like gel phantoms or task trainers, but one of the things I'm interested in is cadaver-based education, and that was about 31%. So like I said, I want to focus, since this is a short talk, on cadaver-based simulation education. So what really is the evidence for that? Now, our surgical colleagues have shown quite a bit of evidence that cadaveric workshops lead to improved clinical skills. For some basic surgeries, it improves the time required to perform a procedure. But within regional anesthesia, it's a little bit less obvious. So there's a lot of regional anesthesia cadaver studies that are looking at how blocks work and things like that. There's a lot less evidence for the skill transfers for novices. In 2012, Barrington did a study looking at novice users for ultrasound-guided regional anesthesia and found that those using cadaver models were able to achieve proficiency with about 28 kind of supervised deliberate practice attempts. So there is some evidence for skill transfer. In terms of cadaver types that can be used for these types of workshops, the two main things that people most of the time think about are formalin and fresh frozen cadavers. So formalin is the formaldehyde cadavers that you probably are familiar from first year of medical school. So that it's very pungent. The tissues are generally very stiff, making ultrasound imaging difficult, especially when you're trying to turn the cadaver's neck to image the brachial plexus and things like that. Now, they are less expensive, so that is a positive. In terms of fresh frozen cadavers, they're much more flexible, but because they're fresh frozen, they're not preserved. They're very short time that they can be used. They are screened for communicable diseases, but there is a possibility for infectious risk. And lastly, because they are such a short time of use, they can be a bit costly. Now, there is a special embalming technique called field embalmed cadavers, and these have been used for many ultrasound-guided regional anesthesia courses. The benefit of this is that you retain tissue flexibility while still also preserving the cadaver. Subsequently, they've done studies also looking at ultrasound imaging and shown that the imaging of these cadavers are a little bit better. They're less smelly, but they do tend to be a bit more costly. So at Mount Sinai, we tried to create our own cadaver course. We started thinking about this in about 2019, and we really wanted to find a way to develop our own cadaver-based course to teach ultrasound-guided regional anesthesia, but also include cadaveric dissection, which isn't included in many cadaver-based workshops. Now, the obstacles we had were probably obstacles that any of you would have had trying to develop any kind of educational course. So you need departmental buy-in, and then you need time, both faculty time and trainee time. And then just kind of a unique thing for us, our anatomy lab didn't have veal or fresh frozen cadavers readily available. So we had to find a way to kind of get around these types of things. Now, before I move on, I just want to make sure everybody knows there will be pictures of cadavers in the next few slides. So just as fair warning. So in order to find a solution for some of those problems, we kind of pitched this course as a pilot program to our department. It was going to focus on trainee education for regional anesthesia and for a few non-regional anesthesia procedures. And that's kind of the obvious solution, but we also wanted to focus on faculty development. Many of our faculty in regional anesthesia who were interested in helping teach this, myself included, hadn't really been in the cadaver lab since the first year of medical school. So this was a new way for us to kind of develop our skills and work with the anatomy lab faculty to kind of learn how to use cadavers to teach. Kind of going along those same lines, we did partner with the anatomy lab, and they were able to find something called a freedom art embalming technique, which is kind of between a formalin cadaver and a veal cadaver. So you really get a lot of that tissue flexibility that you're really looking for the veal cadaver. Additionally, we worked with the anatomy lab to partner with their faculty to give a little bit of pre-course lectures to kind of prime our learners for the course. Now, what we wanted to do is focus on not only just the procedural techniques of ultrasound-guided regional anesthesia, but the sonoanatomy and then dissected out anatomy as well for neuraxial and peripheral nerve blocks. One of the things that since we were dissecting, we wanted to do was include methylene blue in our quote unquote local for our single shot blocks and injecting through our catheters so that as we dissected out those nerve structures and muscles and things like that, we'd be able to see where that methylene blue ended up. And like I said, because we were already doing these same types of things, we wanted to focus on some difficult airway procedures, as well as things like needle decompression of the chest and things like that. So in terms of neuraxial, this is an image on the left of a thoracic epidural done via the paramedian approach. We subsequently then dissected out all the way down to the epidural space and confirmed that it was in the correct space. This was really especially helpful for some of our junior to senior residents who were starting to do thoracic epidurals. We had a skeleton model up and allowed them to perform the thoracic epidural while also looking at the paramedian technique on the skeleton. Now on the right side, we see an epidural catheter threaded from the lumbar space, which is actually the top part of this picture. And the dura has been basically opened to see the nervous structures below, but we injected methylene blue through that catheter and you see that it spread through the epidural space. In terms of peripheral nerve blocks, this is an ultrasound image of the cadaver for a popliteal block. So you get pretty good anatomy. You can see that the quote unquote local is spreading around the nerves. And then when we subsequently dissect it out, you see that the sciatic nerve within the cadaver has a pretty good amount of methylene blue dye there. Now we also did other blocks like adductor canal, femoral, the brachial plexus blocks, as well as ESP blocks and things like that. So in terms of results, the pilot program was a success. So at this point, we've completed this with 86 trainees over the last 3 years. Most participants hadn't been exposed to cadaveric dissection since medical school, and almost 100% of them agreed that this embalming technique was useful for ultrasound-guided regional anesthesia. A little bit more data, we see that peripheral nerve block understanding of the anatomy associated with that. In the orange, it was increased post-course, and then same thing for neuraxial to a little bit less extent. And then we had a pre and post-test assessment of knowledge, and that was consistently increased throughout the 3 years. Now, you may not have access to a cadaver lab or cadavers, so there are other options. I mentioned a variety of fidelities that can be used for regional anesthesia simulation. This is just one I wanted to bring up because it's a meat model that they took a tendon and put through the meat And then on subsequent ultrasound, it looks pretty much like a sciatic nerve or like a nervous structure you see on the right. They compared this to cadaver-based training and found that on subsequent blocks, the performance was more or less the same. So just to summarize, if you're interested in incorporating cadaver training into your program, in terms of cost, there's a few things you can do. You can sell it as like an initial pilot. There are educational grants within institutions or outside of institutions that can help start courses like this. But I think the biggest cost-saving tip I would give would be to try and find ways to share cadavers with other subspecialties or other surgical subspecialties. So general surgery may use the abdomen, but they're not doing anything with the brachial plexus. So you can find ways to kind of use the cadavers so that everybody can get the training they need. In terms of time, if you can use pre or post call days, or if you have dedicated teaching time, that's wonderful. Anatomy faculty can really help teach these courses. You may only need one anesthesiologist to help with the blocks and help with the kind of anatomical considerations for the anesthesia procedures. And lastly, if you don't have access to cadaver training, gel phantoms or task trainers allow for kind of consistent repeated use. And like I mentioned, meat models are much cheaper than the cadavers, and they have pretty good results. And that's the team we have from Mount Sinai there on the right. Thanks.
Hello, everyone. Welcome and thank you for joining. Can everybody see my slides? Okay. So I'm going to be talking today about, sorry, one second, there's some technical difficulty here. Not able to advance my slides. Okay.
Try closing and reloading. Like
Okay.
try closing the PowerPoint and unsharing and come up.
Okay. So, okay, there you go. All right, so today I'm going to be talking about how to evaluate success in a regional anesthesia training program in a competency-based program. So in 2017, the Royal College of Physicians and Surgeons of Canada.
Parvinder, I don't see your slides at the moment.
Okay.
Try resharing and.
Okay, I don't know what's the issue here. Escape. Share screen. Are you able to see the slides now?
Yes.
Okay, so sorry about that. So I'll start again. I'm going to be talking about how to evaluate success in regional anesthesia training in a competency-based program. So in 2017, Royal College of Physicians and Surgeons of Canada introduced the competency-based curriculum for residency training in Canada. And according to this curriculum, the training is divided into a series of integrated stages, starting at transition to discipline, which is kind of the orientation level for the residents. And then they go through different stages called foundations of discipline, core of discipline, and transition to practice. So the CBD curriculum is based on the CanMed's physician competency framework, where the focus is not only to teach and assess the medical expert skills, but also several other roles that the physicians play on a day-to-day basis. And these roles become even more important for a regional anesthesiologist, because as a regional anesthesiologist, we are not only learning to be proficient at technical skills, but we are also performing a lot of things on a cognitive level every day, like a constant decision making and resource management, as well as we need to learn a lot of interpersonal skill management, including being a good communicator and leader. So these skills are more important, even more important for regional anesthesiologists. So at the center of this CBD curriculum is what is called as an EPA. So EPA is an entrustable professional activity, and it is a predefined learning objective for the resident. It's defined as a key task of a discipline that an individual can be trusted to perform in a given healthcare context once sufficient competence has been demonstrated. And a milestone is an observable marker of an individual's ability, and EPAs integrate multiple milestones from various CANMEDS roles. So this is an example of a EPA that we use at Dalhousie. It's related to regional anesthesia. It's called a core EPA, diagnosing and providing management for patients with complications of regional anesthesia. The key features of an EPA are defined, and so that the residents are clear about the objectives, what is asked of them. And the EPA can be assessed on a 5-point Likert scale as a whole, and the different, as well as the different milestones can be assessed individually. So for example, the milestones related to this EPA include medical expert milestones, as well as communicator and professional milestones related to this EPA. So in 2018, this review was published by Elvin Chuan et al., and they describe competency-based assessment tools for regional anesthesia. And they talked about how regional anesthesia proficiency can be assessed in part tasks, as well as the performance of an entire procedure or a nerve block. And in the part task assessment tools, they talk about achieving competency in theoretical sonoanatomy, as well as ultrasound image acquisition, as well as a learning of the real-time needle guidance. Also, the ASRA and ESRA Society have published guidelines and recommendations for education and teaching in ultrasound-guided regional anesthesia, and I find the list of these skill sets is really helpful when we are teaching as well as assessing the residents. The guidelines also describe a 10-point scale of assessing the performance of a procedure as a whole, and this is also a useful guide. So the performance assessment can be either formative or summative. The formative assessment is assessment for learning, for example, how the resident is learning, and it gives us opportunity for ongoing feedback to the residents and self-reflection, and it's a real opportunity for the learner growth. Whereas a summative assessment is assessment of a specific learning outcome or evaluating the overall competency about a particular procedure. In a recent ASRA newsletter, Graham McLeod and Elvin Chuan again talked about tools to assess regional anesthesia with a competency-based curriculum. And they talk about formative tools like anesthesia clinical evaluation exercise, quality improvement projects, something like anesthesia list management tools where the residents are running the list and they're getting feedback on the performance on running the block room. There are case-based discussions, and there are directly observed procedural skills. The examples of summative tools include multi-source feedback, multiple trainer reports, or formal end of rotation exams. So what we do here in our anesthesia residency training at Dalhousie, our residents rotate through the block room twice during their residency. So these color-coded rotations are, the yellow one is transition to discipline, the light blue one is foundations, and the purple one is core. So our residents rotate through the block room twice during their 5-year period, once during their foundation year and once a foundation. It's not particular to PGY 1 or 2, it could lie anywhere on year 1 or 2, but it's the foundations, and the second one is the core. So how we prepare the residents for the rotation, we give them the module outlines before they start the rotations. And the module outlines have all the required training experiences, as well as what is required in terms of minimum assessments. They are provided with a list of EPAs and reading resources. all the residents who are coming through the block room, we host an anatomy lab. It's an all-day workshop, and it's 3 to 4 residents per workshop, and 1 staff plus minus a fellow lead the lab. And it involves teaching of the cadaver anatomy in the morning and sono anatomy in the afternoon. We do pre and post lab MCQs for the residents, and there's a real opportunity for learners to identify their specific areas of knowledge deficit and working through those areas as they go through the rotation. So in the foundations rotation, we use some, or in both rotations, we use something called as direct observations, which are a combination of checklists and global rating scales. So the advantage of using these combination forms is that you can assess both technical as well as non-technical skills. So checklists are objective, and I'll show you examples of those in a moment. They assess the component skills of a procedure, and they are a rich source of formative feedback. The weaker components of a particular procedure can be identified, and it really rewards thoroughness in the trainees. Whereas the global rating scales are subjective, and they are beneficial because they include items assessing non-technical aspects of the whole procedure. Although a disadvantage is the halo effect, which is that the general impression of the resident may can influence the scoring of the individual items. So this is an example of a direct observation form, which we use in our foundations rotation. It's for the assessment of spinal anesthesia in a non-obstetric patient. And we have several steps here in the checklist that can be marked, and gives the resident some chance to reflect on what they need to improve on. And then this is followed by a global rating scale, which is a 7-point Likert scale, and the residents are assessed on that. Similarly, there is a direct observation form or an ultrasound guided peripheral nerve block. And when they come through the block room on their foundations rotation, it is not expected out of them to complete the global rating scale of 7 for the peripheral nerve block. Because it's just the foundation rotation, and it's not an expected outcome of this direct observation, but when they come for their core rotation, they're expected to have a score of 5 or more. Then we do the case-based discussions. In our foundations rotation, we do a case-based discussion revolving around the upper extremity and brachial plexus, and we focus on the anatomy and clinical applications of brachial plexus. Besides the case-based learnings and our direct observations, we also do something called as a direct encounter cards, and these are the daily evaluation cards filled by the faculty members. There is a list of EPAs on the top of these form that can help the faculty member write appropriate comments about those particular EPAs, and the residents are assessed for several things, including technical skills as well as non-technical skills, including decision-making, organization, and situational awareness. And this is the continuation of that form. So in our core rotation, there are similar forms, but the topics are a little different. This is similar, like we have direct observation for ultrasound-guided peripheral nerve blocks. And as I said, on this rotation, the global rating scale has to be above 5. And this is again a similar form, which is a checklist plus a global rating scale. Then instead of using a spinal anesthetic for a non-obstetric straightforward patient, we make things a little bit more complicated. And this is a direct observation for a spinal anesthetic in a hip fracture patient that we use in our core rotation. And again, the EPA or the direct encounter card, the daily encounter cards are a little bit different because the EPAs for the core rotations are a little different than the foundations. But the assessment is on the same scale and regarding the same technical and non-technical skills. And the case-based discussions for the core rotations focus more on the decision-making process. So there's one module that focuses on consent in regional anesthesia, and we have 3 cases different scenarios that we discuss with the residents. And then there's another case which is about the choice of block, and again, assesses more decision-making skills and more cognitive skills of the residents rather than technical skills. And finally, at the end of those foundations and co-rotations, we use in-training evaluation reports, which are summative reports, and we gather information from different evaluators during the rotation that the resident might have worked with, as well as the other staff in the block room, including nurses and our anesthesia assistants. And so this is a summative assessment at the end of the rotation. So in summary, the assessment of both technical and non-technical skills is essential to assess proficiency in regional anesthesia. Both formative and summative assessment tools are helpful for this. The key is to basically learn how to use these tools and how to provide feedback to the residents in a positive or constructive manner. What we have learned at Dalhousie is that when the CBD curriculum initially was launched, both the residents and the faculty members needed coaching on how to exactly use these forms, how to provide appropriate feedback so that the residents, one, can complete their EPAs as well as improve on their skills. So those workshops have been really helpful. And thank you for listening. That's all I have.
All right, I wanted to thank all of our speakers for those amazing talks. So we'll take some questions now. I just wanted to open it up to Dr. Kwofie, and I think just wanted to ask kind of, as your involvement in education, what do you really think are the biggest mistakes that we make as educators, especially in the teaching of regional anesthesia?
Oh, well, there's so many things. You know, I think the biggest mistake, the number one thing I think is that we teach too many things. And I think Dr. Outterson talked about this a little bit. There are so many different techniques that are available in regional anesthesia. And I think sometimes we get lost in all of the three-letter acronyms that exist and lose track of the blocks that really have a high impact for patients and really have a high impact for clinicians. So I think, to me, a focus on the blocks that really can help with GA avoidance for difficult cases, you know, are really the fundamentals for the most part of what are the Plan A blocks for the most part.
Thank you.
Maybe I'll get things started with another question. This question could go to any of you, I think, but particularly around the workshops, Dr. Outterson and Dr. Burnett. There has been a lot of discussion in education about this whole kind of flip the classroom kind of methodology, and I think sometimes it's been limited by the time that it takes us to create the resources to try to offload some of the didactic teaching, you know, to the time before you actually do the workshop to maximize the time in the workshop. But now with, you know, I'd say, you know, a lot more great information as Renews, of course, Asra's Best, Jeff Gadsden at Duke has the Blocktober series, at Pawa, Kijin Chin, I'll have extensive teaching on YouTube channels. To what degree have you guys maybe used flipping the classroom methods to try to maximize the time that you have? And if you have, what resources have you used, and how have you made it actionable, and have there been any successes or challenges? Maybe Dr. Outterson, maybe you might want to start.
I was not familiar with the flipping the classroom phrase until you said it just now, but I think I'm getting my mind around the idea. We do definitely I don't want to use the word outsource, but we do share a lot of other resources with our residents early on in their regional rotation. We've also made a lot of our own, pre-recorded lectures and send them to Jeff Gadsden's videos and other videos ahead of time when we know we have a particular block coming up. It sounded like part of what you're talking about is trying to prime them for learning by, sharing information ahead of time such that when they show up, to learn something hands-on, they're already familiar with that content. I very much try to do that with each individual workshop, sending out information ahead of time so that everybody can review that on their own, use other resources on their own, and then come in and really make it stick by putting their hands on.
Yeah, and I think for me, from like a day-to-day standpoint, I definitely utilize those YouTube sources or journal articles that I'll send to the resident I'm working with the day before and just say, hey, review these things. It's going to be relevant to what we're going to be doing tomorrow. In terms of the workshop, for our workshop specifically, we send a little bit more how to dissect tips. So they're like pieces of a dissection manual so that piece doesn't seem as scary, because like I said, many of our residents haven't been in the anatomy lab in 4 years or more. So trying to take that piece of the puzzle and get them a little bit ready for that so that they feel comfortable doing the actual dissections after they do the block is something that we really have integrated into our workshop.
All right. I think another question I think a lot of people are asking, just because you guys proposed a lot of different great, ways that you have either workshops and learning opportunities for your residents, is really how to balance, how to have the opportunity to do so much of that. Like, how many times a year are you running a lot of these workshops? Or are you running things before each rotation if it's a month? And how are you balancing that with all the clinical pressure and work, and also incorporating that regional anesthesia learning into the greater education of all the other things they have to have involved in their lectures and simulation sessions for the whole breadth of anesthesia?
I know for us, we would love to do this workshop at the beginning of every rotation, but it's just not feasible. So we found a time in the spring when the anatomy lab is relatively not busy with medical school or with other residency programs, and that's when we do it. We just try and get as much done in that week as we can and do multiple days.
So us at Dalhousie, we do this workshop 4 times a year. And so we have 13 blocks of rotations, residents going through the block room. So we do the workshop 4 times a year, all day. And besides this anatomy lab, we also have our academic teaching for the regional anesthesia that comes in rotation. So it comes every 2 years. And during that also we have 1 day of lab, which is sort of with more residents, more number of residents, as you said, Dr. Outterson, 12 to 15 residents. But for our regular workshop that we do every year, every 3 to 4 times a year, we have 4 or 5 residents and 1 faculty, and we spend all day learning anatomy in the cadaver lab in the morning and doing the sono anatomy. And we use standardized patients or volunteers for scanning. So I find the feedback from the residents, and they feel that they are well prepared coming into the rotation. So yeah, it's been quite a success for us.
And the way we structure it at Stanford, I wish we could do it at the beginning of every rotation, but instead we built it into the CA years, kind of trying to anticipate what each class would likely need at different points. So there's 2 workshops for the CA1s, 2 for the CA2s, and 3 for the CA3s spaced throughout the year. So the CA1s start with introduction to scanning, femoral and adductor, and then later in the year do some basic blocks, a little bit of brachial plexus and popliteal. The CA2s have a comprehensive upper extremity and then a comprehensive lower extremity workshop are there too. And then the CA3s do chest and abdominal wall blocks, Neuraxial blocks is a new one that we just added in this year, scanning for neuraxial. And then the final one is the review of blocks that you're going to need in private practice. So while we can't perfectly space it for each rotation, we try to make them as relevant as possible for that year's learning. Oh, and then the structure itself is each CA class has one afternoon a week where they have protected lecture time. So it's just 90 minutes that they have protected for that afternoon. And that way they're guaranteed to get out of the OR.
That's great. The question really for any of you, I guess. Certainly I love cadaver labs. I personally love going to the cadaver lab myself. I learn so much every time I go to the cadaver lab. However, and Dr. Burnett highlighted, how costly and resource intensive they are, and not all institutions necessarily have a lot of access to cadaver labs. And in addition to that, the technology that's starting to exist for anatomy apps, some of them with augmented reality and virtual reality for even low cost 3D immersive things, and I wouldn't be surprised if there's sort of immersive virtual reality anatomy in our near future. Do you guys think that in 5 or 10 years that we're going to be going to the cadaver lab still, or is this going to eventually become a historical thing?
I've used some of the technology from a few different companies, whether it's augmented or virtual reality, that are really looking at the anatomy, and it's very much focused more on kind of replacing that first year of medical school anatomy, whereas what we are trying to do, I think, with all of us is really focus it more on regional anesthesia. And so the procedural aspects of the cadaver lab are very difficult to replace. Task trainers are good, but I don't know if you've all seen, like, the interscaling task trainer doesn't really look quite like an interscaling block, right? So I think as the technology gets better and there are more things that are focused more towards the procedural and related anatomy for regional anesthesia, I think that those things may kind of take away some of the opportunities in the anatomy lab, but I don't think the technology is quite there yet.
Okay, thank you. And Dr. Sodhi, I had another question from the audience. So I wanted to ask you how you deal with assessment fatigue in residents and faculty with CBT.
Great questions. So yes, that's a reality. There's a lot of paperwork, both for the residents and as well as the faculty. And our competency-based program actually has gone under a lot of review because of the similar things brought up by the residents to the residency program committee about the assessment fatigue, staff not having, a good idea about how to fill the forms so that the residents can get their EPAs. So what we have done for particularly for the EPA forms, the first thing we have done is that the daily encounter cards, sometimes we try to club them. So if a resident is working with a staff for 2 or 3 consecutive days, we do not expect them to do those daily evaluation cards. They can fill just one card based on all 3 days of work. And the residents are only allowed to give the faculty only 1 form per day, so they cannot ask for a direct observation as well as a daily encounter card. So that is something we have tried to do. To help the staff deal with the fatigue, we have sort of given them cues, as you said, as you saw on the slides, that we have those EPAs typed on the form so that the staff have some, even if they are filling the forms a few days later, they have some memory of what the resident was trying to do and what they were trying to ask for an EPA ask. So that one we have done. And then we didn't used to have the type of blocks performed in the day. So we have tried to add that to help with some remembering what was going on during the day. So we have tried to do that, plus the workshops where we have tried to train the staff how to actually fill out those forms has helped. But assessment fatigue is real, and it's not going to go away soon. But those are some things which we have done to sort of mitigate that fatigue from the paperwork.
Great. I've been told we have 5 minutes left, but there was a question from the audience, and they wanted to know from each of you, for community anesthesiologists, granted everyone's practice is a little bit different, but what do you think are the top 5 most important blocks? Can everyone one at a time give their top 5? Only have 5 minutes.
Okay, I was in private practice for a few years, so this is easy. I'll just go the top 5 that I used to use there the most. Interscaling for sure. Supraclavicular, adductor canal, popliteal, and I'll throw in an axillary too. I know that's 3 brachial plexus, but that's what I used a lot of, because you can't do a supraclav on everybody, and sometimes the axillary is just right.
So I would go with interscaling axillary for upper limb, adductor canal, and popliteal for the lower limb, and I would also go with rector sheath blocks.
You said all the ones I was going to say. Although personally, I like the infraclavicular best, but I think for just everyone, I think the plan A blocks are good.
I think it's especially a tough call with the fascial plane explosion out there, really figuring out what's best in that realm. I think another question, would be from someone in the audience was really, what are the best resources for faculty development, as far as education, and what, resources as far as what novel techniques are out there to educate our residents, especially if you don't have the resources like Cadavers and, fully stocked sim labs and things. Where can they get this information?
Anesthesia Toolbox is pretty good for these kinds of things. And I think I would venture to guess that many departments have access to that at this point.
Mm-hmm. Lots of great YouTube videos, as Kwesi was mentioning before. Dr. Gadsden's videos are great. Lots of other videos out there that are great, as long as you know the source that they're coming from.
And I know there was. Go ahead.
No, I usually, before the residents start the rotation, I usually provide them with a comprehensive list of reading material, and from specifically teaching materials, I direct them to either Kiji Chin videos or Jeff Gadsden's YouTube videos. And then there are some that have been developed by some one of the friends at the University of Western Ontario. So they have recently sent me some clips of their own. There are some instructional videos for the residents, so I use those for the teaching purposes.
I'd also say, of course, we have the ASRA News How I Do It series, which I think is very good. We talked about other websites and of course NYSORA. I think there's a ton of videos out there on YouTube, a ton of web content, but I think you need to be careful about the source that it's coming from. Not all sources are equal, so you want to make sure that you're going somewhere that you have good quality materials.
Yeah, I agree. I think it can be information overload out there when you delve into it. So I agree. A lot of the Jeff Gadsden videos, ASRA, NYSORA, things like that post a lot of great resources. Anything on faculty development that's out there for anybody as far as what you would recommend to just improve the actual skills of, education and delivering the information? I think those are things that I think we all need to improve on. I think between your institutions and also some of the societies have, talks and different things about specific teaching techniques. And I think that, that's something we all need to strive to improve on. All right, so I think we're really at our time that we are wrapping up. So I just want to thank all our speakers. I know there's still a lot really great questions out there. I know that a number of us are on Twitter and posted their Twitter handles, so I think you could always reach out to us there to get any additional information you might have. But it's been a great session, and I wanted to thank our speakers as well as my guest host today. It's a different topic from what we normally do, but I think it was really fun and really important. So thank everyone for being here with us tonight. And I just want to remind everyone to put it on their calendars that we have our next Hot Topics in Acute Pain and Regional Anesthesia on October 11th. And then we will be discussing the very challenging topic of acute pain management in the complex chronic pain patients, some patients we see every day, and it's a challenge every day. And I think it's important to talk about these important patients more and be up to date on the literature. So it's been a really great session. This concludes today's program, and I'll see you all in October.